Welcome. Thanks for joining us for ADA highlights from the 2024 American Diabetes Association conference, which was recently held in Orlando. At the conference, we saw some real groundbreaking research being presented. And today I have the distinct pleasure of interviewing one such investigator whose study was highlighted at the conference. So welcome, David Preiss. Dr. David Preiss is a researcher and a clinical academic in the Division of Metabolic Medicine at the University of Oxford. And he presented on behalf of his group the results of the LENS study, which is essentially looking at the role of fenofibrate in diabetic retinopathy. Dr. Preiss, welcome.
Thank you very much for having me. I'm glad to have the opportunity to talk about the trial.
Excellent. So everyone's talking about the LENS study. Can you tell us in this study, what were the patient population that you looked at and what were some of the key results that you saw?
Okay, so starting off with the population, we sought to identify people to join the trial who had any kind of diabetes apart from gestational, so type 1 or type 2 diabetes, and they had to have what I would summarize as mild to moderate diabetic retinopathy. So not at the stage where they're needing treatment or needing to see a specialist, at least in the UK system, but not so early as having no disease. A kind of almost, shall we say, a sweet spot where the risk of progression was sufficiently high to be able to study in a trial over about 4 years. I guess the other key point to mention is design-wise in the trial. Scotland is where we ran the trial. Scotland's a small country, relatively few people, but what's a beauty in Scotland for clinical research is the presence of a national diabetic eye screening program. So all individuals aged 12 and above with diabetes have very regular imaging of their eyes, photographs taken of the retina, graded by trained professionals using additional automated software. So it's a beautiful program in place for 20 years. And the presence of this program allowed us to identify sufficient numbers of people across the country. So we identified 1,151 participants who were randomized. Just heading into the COVID pandemic, probably would have randomized even more, even though in a small country. And we followed them up for 4 years. Trial was heavily streamlined. So they only had a couple of visits face-to-face with the research nurse up front. After that, everything was done through the telephone and we posted out the study treatment to them. So highly streamlined. And then we really performed regular linkage to their national records, whether that be for national diabetic eye screening results and indeed the images, which we have for further research, biochemistry results, hospitalizations, etc. So we linked together kind of classical contact with the patient together with linkage. So the key result, I guess, was over the 4 years of the trial, we did find a reduction in progression to our primary outcome. Now, our primary outcome was essentially progression to the severity of disease where you needed to go and see a specialist or whether you may have needed treatment for eye disease. So a composite of those two things. And that happened in 29% of patients on placebo, 23% of patients treated with fenofibrate. So overall, relative risk reduction, about 27%. And, obviously very happy to see that. And also it was strongly supported by some of our key secondary outcomes. So for example, we looked at any progression of disease. So not necessarily having to get to a severe disease. That was almost identical, 26%, highly significant. And in addition, we looked at reports of macular edema, obviously problematic condition where you're really getting at risk of needing treatment. And there again, we saw a substantial reduction, smaller numbers of events as expected, but still in keeping with the primary. So yes, overall, very pleased both with the results, but I think in particular with the design and how the design of the trial managed to deliver.
Yeah, very well conducted study, Dr. Preiss. And I must say I was in one of the front rows there listening as the results were being discussed. I found this very impactful. We are welcoming back an old friend, fenofibrate. Now, as you know, this is not the first time that we've seen some results with fenofibrate in the field of diabetic retinopathy. Previous studies have also been done a few over a decade ago. But any reason why it didn't really catch on after those initial studies?
Yeah, this is an important question. First, I think it's worth mentioning that a few countries around the world did license fenofibrate for diabetic eye disease therapy. Australia is most notably, but they're certainly in the minority. The big regulators would not accept data, mainly because the trials that delivered these promising results were essentially cardiovascular outcome trials. And the cardiovascular outcomes in those trials were not significantly improved. And so the chance of a false positive in the field trial, in the Accord trial, was certainly there. I mean, the field trial results, I think, are most notable. The reduction in laser therapy that they saw did look very compelling, one must say, but I don't think sufficiently compelling. We really needed dedicated trials where the primary outcome was eye progression, diabetic retinopathy progression. And so given how these things do take time, it has taken a sufficiently, a number of years following those promising results to finally deliver. Also, as you say, it's an old drug, limited probably interest from the pharmaceutical industry, and these trials do take a long time. But I think managing to pull together a trial with a very streamlined design meant that we could do it, in a very inexpensive way, sufficiently powered to deliver what I hope is a compelling result for clinicians out there.
Excellent. Dr. Preiss, what I found really impactful when you showed the baseline characteristics of individuals, the triglycerides, when people were entering the study, they were not elevated. So triglycerides, mean triglyceride was in the reference range.
Yeah.
So we know it's not a triglyceride lowering phenomenon, but any ideas as to what could be the mechanism of action here?
I guess you raise an additional point, actually, to pick up from the previous point. The other trials that have been conducted had eligibility criteria, which included lipid thresholds. And one can see why that was done for the cardiovascular trials that were being done. But there was a strong reason to suspect that if the drug works, it may not be due to changes in circulating lipids. So as you rightly say, the triglycerides in our population were not particularly high, and they were not fasting. They just randomly taken. We did see a reduction in triglycerides of about 13-14% on average during the trial. But in absolute terms, I mean, the total cholesterol in the two arms of the trial, they differ significantly, but in absolute terms, almost nothing. You're talking 4 milligrams per deciliter. That's nothing. And so that really, I think, plays to at least my belief that the drug is working directly in the eye itself. And there's compelling data, mainly from animal studies, animal models, a beautiful paper from, I think, 2013 by Chen and colleagues, where they gave fenofibrate either systemically, like we did in the trial, or intraocularly with intra-eye injections. And they saw really substantial and very similar benefits in the eye, substantial reductions in VEGF levels, substantial changes and improvements in leakage of retinal vessels. And so I think the trial, our data obviously doesn't really get at the heart of why or how the drug is acting, but I think in totality, it ever more suggests that the drug is acting directly within the eye. And maybe one final thing to add on, we didn't have a lower dose option in the trial. So for people who had subnormal kidney function, they only took the tablet every second day. They didn't take it every day even. And even they saw comfortably significant benefit. And arguably the exposure they had was fairly limited to the drug. So I think it opens up a whole lot of avenues for, future ideas anyway about what this drug is doing in the eye. And who knows what else it might be doing. There's even promising data from years ago post the field trial where they followed up a subset, and it looked like it gave renal benefits as well. So, there's a lot of avenues that we can actually tackle in the LENS trial going forward.
That's so fascinating. It's really amazing. One last question for you. So for clinicians like you and I, once there's a high likelihood that the results are so good, we may start, utilizing this in our clinical practice. Your study was a long-term study. What do you feel in clinical practice once people start using this medication? Is this going to be one of those start it and forget it medications, or will there be a point of time where you may want to stop the medication, perhaps revisit? And what if there's still progression of retinopathy despite using this? Does that mean that the medication is probably not effective?
Yeah, all good questions. I think it's early days, firstly, with our trial. And I do think it's worth emphasizing there's a couple of other trials going on that will, they're going to take another 3-4 years to wrap up. But I hope that we will start to see increased use. It'll largely be off-license use because the drug is not currently licensed in most countries. I hope that diabetes guidelines will take it on board. And I very much hope that we'll be able to persuade some of the producers of the drug to actually pursue a license for retinopathy. You're right that the drug did substantially reduce progression, but clearly a substantial number of people nonetheless did go on to develop progression. In our trial, over 70% still progressed. So I think there's still a big unmet need for other strategies to come along, but I would certainly be advocating for long-term therapy. Having said that, I think there's one notable clinical quirk to be aware of, and people in the lipid world are very aware of this, but not necessarily everybody, and that is the effect on creatinine levels. So it's entirely reversible. It puts your creatinine levels up. It makes your EGFR look worse, entirely reversible. But you need to have an appreciation for this, because if you're not aware, you could potentially treat somebody, check their kidney function 6 to 12 months later, and erroneously conclude that their kidney function has deteriorated. So there may well be a case for starting the therapy, measuring kidney function maybe a couple of months later, just to almost get a new baseline, because it is a notable change in EGFR. I want to stress, not renal damage. We're talking potentially renoprotective, but nonetheless, the EGFR does drop while you're on the therapy. But if people can get that, message and understand clinically using it like that, then I guess the advantages are substantial. It's a cheap drug, and could be certainly translatable in the UK, countries with national systems. I know that the systems elsewhere in parts of the world, certainly in the US, are quite different. But I think a bit of time, as people get used to it and more comfortable with the drug, I would hope that we'd be able to see substantial use of it for this condition.
Well, thank you so much, Dr. Preiss, for sharing the results and your clinical insights. And we really appreciate having you today.
Thank you very much for the opportunity. It's nice to speak to you.
So that was Dr. David Preiss, the principal investigator for the LENS study. This is Dr. Akshay Jain, endocrinologist in Vancouver, Canada, signing off. Don't forget to check out some of our other videos with ADA highlights.